we do frenectomies. Infants, children, adults. I've seen this full scope. I use different techniques. We have scissors, we have the 2 straight mosquitoes, a scalpel, and some suture, and then we have laser plus possibly suture depending on the case. And so we want to share that with you all. And I used to train residents. I'm still appointed at OHSU, which is one of our med centers in Oregon, in the ENT department. One of the non-financial disclosures. I'm not there as often as I'd like to be, just because it's not paid. But anyways, location. So we live right on the border of Oregon and Washington, right on the Columbia River Gorge. I don't know how familiar anyone is out there, but basically an hour east of Portland and Vancouver, Washington. So what we're doing is putting together a course that I'm just basically training residents in the operating room, in clinic, in a big med center that you know, we were able to really pass a lot of knowledge, skills to these residents in a short amount of time because it was a general practice residency. And frenectomy was one of many procedures that we did because when we're going to the OR with special needs patients, medically complex patients, we're doing everything we can. If it's a complex or a special needs patient, we want to tee them up for basically the next 12 to 18 months, right? Because we're going to see them again for GA because they're, you know, combative, orally defensive, and they can't tolerate care within a traditional dental setting. So therefore, we have to go to the operating room. For the medically complex patients, sometimes we did the frenectomy on them too, but you know, it might have been full mouth extraction. It might have been extract the wisdom teeth, fill all 28 teeth. It might have been, you know, just tons of different procedures that we did. Frenectomy was one. And yeah, so make sure we use, like I said, CO2 laser and scalpel. So what we're putting together is CSI Oregon, and we're more or less like gauging interest. Would you want to travel out there and do frenectomies? Would it be good here? I'm indifferent. I love teaching. I love sharing knowledge, passing it to you all, hands-on. I like you to basically see one, do one, teach one. And with frenectomy, it's pretty simple. And so I want to get reps in your hands. The children and the adults, very, like the children, depending on the age, it can be one of those things where we, you know, on a 2-year-old, holding, you know, stabilizing them and making sure that we don't injure them or ourselves while we're doing the frenectomy is one of those things that takes finesse, takes a great team, takes, you know, scope of care in terms of myofunctional therapy, and we can get into all that. But we're about an hour from Portland, and then 3 hours from Mount St. Helens, and then it's in the beautiful Columbia River Gorge. So that's what it looks like. That's where we live. It's awesome. Hood River's on the left, White Salmon on the right. Portland is through those clouds and mountains. And then let's see. So I add high value, simple procedure to all ages. Really adults and kids, and then with the infants, we can teach you. A lot of courses don't have hands-on, and that's what I want to change. I want to be able to share that with you all. The infants is probably the most, well, they're infants. I'm familiar with it, with working on them intimately because I did nasoalveolar molding. It gave me, which I don't know if you guys are familiar with that, but in the hospital, cleft kids, unilateral, bilateral, we basically mold the palate for 3 to 5 months. We get them pre-op and ready for their first surgery. So we connect the alveolus, we connect the soft tissue, and it's an awesome procedure because we saw the families every week for 3 to 5 months. And we're making minor adjustments with you know, the soft tissue reline material to their molding plate, and we're basically hand fabricating it. I'm sure by now, because I don't do much of that anymore, It's done by printing, but anyways, you're gonna learn, you know, the minimal setup, which is basically 2 straight mosquitoes for an adult and a scalpel blade if you don't have a laser. We'll teach you the medical diagnoses, the ICD-10, the medical procedure codes, the CPT codes. We have, and then keep your patients in your practice. This is such an easy procedure. A lot of people don't like they're scared of the tongue, but I mean, you guys see a lot more stuff that's more complex than a lingual frenectomy. And so I want to make it easy. Another picture of where we're at. So that is a case that got referred from an orthodontist. And we use a light scalpel laser. I don't have any relation with them in terms of any disclosures. Once I started to really get in that space, and then in the hospital, to get laser privileges is super difficult. And you had to go through this course and this course and this course and go through, you know. So when I rotated with ENT and all the different specialties, we used lasers, which is awesome. But to be faculty and an attending, it was really tough to get it. So for my cases, I just didn't use it. We just did the old, or the tried and true method of 2 straight mosquitoes and a scalpel on pretty much any frenectomy we saw. With the laser, oh my God, the post-ops are amazing. So that is probably the highest standard of care, in my opinion, for most of what we're doing, and we can get into the nitty-gritty of things. But overall, this is I forget how old she was, but
she was 12 years old.
Yeah, and we'll go through her case in a little bit. That's Multnomah Falls, and it's a great waterfall. I don't know. You probably don't know that. All right, so there's one case. I have so picture-wise, right? I've been doing this a long time, so like I have a whole library of pictures. Some of them are like, you know, I don't know when we did this case, but you know, I snapped a picture. Some of them, a lot of my pictures live in Epic, and I don't have access to all those patient records because I had on every case, the residents use their phone, the app in Epic, take the picture. Awesome, but a lot of that stuff is not with me now. So this is kind of a collage of what I have from, you know, over 10 years. So this is with 2 straight mosquitoes, scalpel, and you can see kind of the end product. So another picture, beautiful, gorgeous, right? Yeah, you want to go there, right? That's Mount Hood. Yep. This is looking out towards. This might be Dog Mountain, but I just kind of snapped some pictures from online. I don't know. So this is us in November, I think, or one of the times that we were out here last. So one of the things that I love about CSI is that hands-on transfer of knowledge, not just I'm going to talk at you and do the surgery. I love like getting in there and letting you guys do it. And so that's what I want to share with y'all with the frenectomies and the different ways of doing it. So, gosh, look how pretty, man. You guys like whitewater rafting? Yeah. We have the White Salmon River.
It's right by us.
And it's like world class, like, oh, it's gorgeous. So, you know, just saying. Well, that's where we're having maybe a course in October. Sorry. Anyways, so this is kind of what we're thinking in terms of the course. Now, there's a lot of courses out there, right? There's Dr. Zaghi's, there's Baxter's, there's other ones, but I don't know how hands-on they are. And so I would just want to be able to kind of change that if we can, right? And I've already done it, especially with the children and adults, because, I mean, in the OR, I'm like, all right, it's your turn. Step in and do it. So. I want you basically, you know, operating. So 7 frenum, right? And then I think your slide's next. We didn't. I mean, we're.
Like in 2, yeah.
Yeah. So 7 frenum. You got your max labial, mandibular labial, the 2 buccal on the lower, 2 buccal on the maxillary, and then the lingual frenum. So this was one of our patients that we'll go through as well. She was severely tongue-tied. I forget. I think she was 30.
She was 40.
40.
Yeah.
So, all right.
So basically, why are you doing this procedure? So we right now are like really seeing a lot of babies and moms. And when those patients come in, they're usually a unit. You're going to see symptoms presenting in the baby, and you're also going to see symptoms presenting in the mom. Sometimes they weigh differently. But basically, what we're doing is like you can probably identify a frenum on most of your patients that you see them on, but we're treating a symptom-based frenum. So if we see it and they're not having any problems, the baby's gaining weight, you know, there's a plethora of things. Sometimes they're misdiagnosed, so it's all kind of cues. We're dealing with mothers who are trying to nurse babies and they're in a lot of discomfort and they have a lot of symptoms. And so in the course, we'll go into depth into what you're kind of looking for a mother-baby dyad of symptoms when they're coming in. And then for children, again, this is going to be your like 1-year-olds to 12-year-olds, and you're going to be usually getting referrals from like a speech and language pathologist or a myofunctional therapist, oral myofunctional therapist. And again, language is usually the biggest thing you're dealing with. In you know, preteens, you're looking at diastemas, and we're dealing with orthodontia. And so we're usually looking at that labial tie. But you're also seeing snoring, mouth breathing, TMJ issues, and other pain and discomfort, things that may not present as a lingual tongue tie. And then adults, you're gonna have a lot of like mouth breathing. You're gonna identify it and they're gonna be like, oh yeah, I just have had this issue for years, or like they've always thought they talked funny, or they feel tight in their neck. They can't clean their teeth as well if they're super tight. Again, just like a plethora of issues that you can kind of identify as potentially being caused by that lingual frenum being still attached pretty severely. And then what we do in our practice is we're team-based care. We could not do this well by ourselves. We're not going to turn people away, but we like to advocate for them to be working with another provider, and that's going to be lactation with your babies, as well as a body worker. And the reason why is they are educating the mom on proper feeding. They're able to, you know, kind of get in there. They're working with just different ways for that baby to latch properly, and they're identifying it. And a lot of your lactation consultants cannot diagnose it, but they can refer out to you. And then for your kiddos, you're looking at speech language pathologists as well as oral myofunctional therapists. In our wheelhouse, what we're really working with is we have a good couple of lactation consultants, and we also have myofunctional therapy. And with myofunctional therapy, you're retraining the position of the tongue, and you're retraining their neuromuscular system so that you could potentially not even need the frenectomy, depending on how severe it is. But we like to work with them pre and post procedure, because now you're getting that rested tongue position back up in the palate, and they're being trained properly. So, and again, we'll get into this more in depth, but oral myofunctional therapy, as if a lot of you know, is like growing and growing, and there's a lot of interest in it. It is still a little bit like, what kind of provider are you getting and what kind of training do they have? Same thing with lactation, but those are the two people really work with. And then we're finding that body work is kind of essential, especially for adults post-procedure, and infants. Infants are usually really tight around their mouth, and when you're releasing these tongues, you're seeing a lot of, you know, like tightness is being released. So if you're working with like chiropractic, massage therapy, something, so trying to really kind of vet and find some good people to have on team with you to offer this as in addition to the frenectomy. It's not a requirement, but we find that our patients perform much better. They are monitored more closely than we can, and they're able to have a much more positive outcome from that frenectomy procedure.
And then you're not educating as much. Like, you're leaving all of that, you're just coming in, you're doing the surgery, and then you're handing it back off to them. And it's a beautiful, magical thing, I'll be honest, that works really well. So, and we all like to do surgery, not necessarily, you know, figure out what's gonna help them, educate them best. Like, you know, if you need an implant or not, you know, like all of that is just handled, and then you're just like, oh my gosh, they showed up for surgery, they're here, they're ready, and let's go, and then the surgery's done, and then you move on, and then you get beautiful post-op. So.
Is that because of the practice and how you built that up, that there's a referral system there that you are, I mean, because I do that a little bit in sleep, they're referred over to me through sleep, just go right back to your provider, we provide the device, everything's already done.
Yeah.
But when you first start, it don't work like that.
No.
Right? You've got to go out, you've got to market yourself, you've got to become that referral source from these doctors to provide these things, and then you're medically billing on top of this for this procedure.
Yeah.
Yep.
On top of that, which is the reason why these providers are referring to you in the first place.
Bingo.
Because the minute you're a dentist, it's not covered benefit. We're not
Bingo.
gonna do
Yeah.
it.
And more insurance companies are actually dropping frenectomies from dental because they're labeling it that said there's no teeth involved. So why are we billing it as such? And it is the same thing. We're right now like we're pretty robust just by word of mouth. We didn't even really need to advertise too much based off of the way we grew, but from the private practice end. But you're spot on, yeah.
And then how can we help others that don't want to build a big practice of like referrals from folks? It's like a lingual frenectomy is so easy that you don't have to have a laser to do it. To do it well and do it right, and you can serve your patient to the highest level, even if you don't have myo. I'm not saying that's not the best outcome. It's just, I mean, there was a patient here that we were going to address because he was so tongue-tied, he couldn't even talk. And I'm just like, okay, we got to release that. I don't care if myo is involved or not. Like, I want them to be, but it's just, I mean, it's just such a game changer, right? I had another patient this last week, kind of the same thing. Her tongue was like this and so severely tied, and it was just like, oh my gosh, you're 56. How did you make it this far? And so it's just like, okay, we don't have to have that whole referral process. That can be a patient in your practice that you can just be like, help. And then I really want to share the knowledge and wealth of assessing this, right? Because as dentists, yep, looks good. No tongue tie, and like missing so much. And that part is honestly, as I explore this more, the more it's like, all right, let's distill this down more to like, you see this and this and this. All right, this is a tongue tie. This is the grade that we're going to use, and then move on. And so I'm actively, going through that. Zaghi has a really good functional test for adults. Yep.
Yeah, so what percentage of these people that come to you have dentists are seeing their dentist?
Honestly, we work with a lot of lactation specialists with the infants, and so that's the other part. Where do we really want to be the only, or do we really want all the children and adults? Because there's a lot more complexity with those in terms of the myofunctional relation and all that. So, but we do it, and what we're finding the more that we ask people is like no one's doing adults in their practice. And there's nobody in our area, in Oregon, Washington, especially where we're at, that are doing tongue ties. And they've talked to like 10 or 15 dentists. And so it's just crazy. So we're like, yeah, we'll do it,
We're getting a lot of like orthodontists referring right now with like the diastema for the labial. But there's a lot more interest kind of drumming up. So we're in a like fun flex phase with a lot of it, but we like are mostly babies, but we're, in regards to dentists referring to us, is kind of more just orthodontics at this point.
It just seems like there's a huge lack in this room of people understanding the need for it, right? And I'm just curious, how many of these people have dentists that are not seeing this? They're doing their exam, they're staring at teeth.
Yeah.
They're not asking the functional questions.
Preach it, brother.
Yeah.
Because that's exactly like.
I see them all day long, and I do them.
Bingo.
Okay, yeah.
I like
Beautiful.
It's the easiest thing in the world.
That's what I'm saying. See, I love that because like that's. I mean, it's so simple, and
Yeah.
like I want to share that knowledge so we can treat our patients to the highest level because I don't think they are, because the tongue assessment really isn't being done well because it's confusing. There's 5 different scales. There's a Kotlow. And it's just like okay. I want to distill it down to like. See this, let's do this.
Yeah.
And so that's kind of the goal with the course. So, contraindications, really not many. Oral version, huge.
That's a feeding issue in infants. So if you're doing infants, your lactation consultant should be spotting that, and you should not be seeing those babies. They kind of present a little bit similarly to just the regular tongue tie symptoms, but they are like refusing all sorts of food. and like they're losing weight, and it's not because they're not trying hard. They just like they do not want there's a lot of different reasons why oral aversion is a thing, but they need to be working with like an OT or somebody specifically who specializes in that before you do the frenectomy. Because if you do the frenectomy on it, you're actually going to make it worse because they're already averse to having stuff in their mouth orally. So once you do that frenectomy, it's just going to kind of continue to decline. So your lactation consultants should be spotting that. But again, that's if you're working with infants specifically.
Pure-Robin sequence, I mean, you're probably not going to see that. I saw a lot of that stuff in the hospital. So like Cruzon syndrome, 8-Bert syndrome, Pure-Robin, cleft, you know, Marfan's, all that stuff. I've seen it, manage it dentally, medically with it's team-based care. You can't do that alone, right? Probably not going to see that. But if you did the frenectomy on someone with that, they don't have good muscular tone. They can basically almost swallow their tongue if you release it. So like just avoid it, you know. But that's really it. Bleeding disorders, I saw a lot of those in the hospital too. We worked with the hematology department specifically. They did like, you know, if it was like von Willebrand's, if it was any of those, you know, bleeding disorders, what's the one, Glatzman's thrombocythemia, where their platelets don't work. It's a team thing. Not gonna probably come into that. Caregiver compliance. If the caregiver doesn't want to do the stretching with the children and the infants, then postoperatively, then that's not going to be a success in those cases. With the adults, they can probably avoid the compliance and still have somewhat success, but it can still scar back down. So compliance is a issue, you know, or it can be. So this is the assessment. The fourth one, the HAT LFF, or the Hazelbaker, that was in the oral surgery board, right? Like that's how they assess it. But it's just an assessment tool. And I was looking and comparing what we're doing on infants, and we're working intimately with the lactation specialist. And you know, if we would follow that assessment tool, we wouldn't be doing a lot of what we're doing, even though it's technically, according to them, you don't need to do it. We see, I mean, it's almost like a magic act. You do the frenectomy and then they latch, and it's like you just gave them a beautiful next like 2 years, and it's just awesome. And it works. And so the Kotlow class, like that's assessing, you know, there's a labial and then there's a tongue. I'm not going to get into this, but we'll get into it more in the course. And then Zaghi has 1 and 2, which is basically a functional test of the different frenums. And then there's something I looked at with the OMD screen, but it's kind of in the works. I don't see any new publication from it. So instrument set, I'm just going to go over this a little bit, but again, you get more of this in the course. Groove director, you know, 304 chromic gut. 2 straight mosquitoes are for the kids and the adults. Those are like amazing because they just, well, I'll show you. So I like non-cutting needles, tapered in the mouth because it's soft. It's super, you know, friable, or it can be. So I love tapered needles, and I've been using them my whole career. The infants, child, and adult techniques are a little different. With infants, they can have the methemoglobinemia, right? We don't want that, so we just avoid it. Use straight lidocaine, 2.5%, 5%, whatever. You're not using the benzocaine. Adults and children, we're past that. We don't have that risk, so we can use the traditional, you know, topical and then the local, and then the stepwise approach that works really well. I don't know if you all know that, but we can kind of walk you through it. So here are the steps to the maxmandibular, you know, labial frenum. I'm not gonna. You'll probably get the slides, you know, on the website. Again, instruments. Let's start walking through some visuals. So this was one of the cases I saw. I mean, do you see a lip tie there? I don't. Super severe, right? This patient also had some other things going on. Bald, looks like fissured tongue. They had some retained primary canines and some other things, but there's a better visual. So like this thing is so tied that they can't brush the teeth very well because the frenum is like right there, right? So just some more pictures of it, side view. And so this was one of those that we took the pre-op pictures, we took the post-op. I didn't really have the whole series, but you can see that we addressed it. And then I have a whole series of slides showing you the exact steps for the lingual frenum, thankfully, so that you can get a visual, but you basically apply it directly to this case. So you can see how much freer that lip is, how they can get the bristles of the toothbrush at the margin of the mucosa and the gums, or the teeth, to actually brush their teeth well on 8 and 9. This is another case that I was like, well, do we need to do it or not? I mean, but that lip was so tight. I usually use a perioprobe to see, do we have any recession? And I don't remember the age of this patient because remember I just kind of got this picture from wherever. But I used the perioprobe to see if we have any recession. Didn't see much, but when we did the frenectomy, it released very well. This was, I think, the same patient. Yeah, so I think this is the same patient. So we did the labial and we did the mandibular. And then it can be a little tougher with the straight mosquitoes to get it in there because there's just not much space for those beaks to do 2. So you just do 1 and it works out really well. Here's some other cases where, you know, massive relief. I know that you don't see the pre-op, but a lot of these were tethered like that first case that you saw. So same here. One of the things that I had in my way was that nasotracheal tube. So we had to work around that a lot, right? I think that's the same case. You can kind of tell from the demon. All right, so lingual. Basically, it's so simple. The process, once it's diagnosed, once, you know, myo, if they work with them, you basically take a straight mosquito. You place it on the underside of the tongue. First you assess it, and then you anesthetize it, right? So you elevate. If the patient's awake, so we didn't always do this under general anesthesia, we just happened to do this because they were tongue-tied. We had a bunch of other stuff to do. So, so you give local, and then this picture wasn't great, except you can see the beaks being placed, right? So sublingual ducts. So just to get oriented, place the beaks, and then you just carry it down to just above the sublingual ducts. Block those things out. Don't touch them. It's not fun trying to repair that or calling in someone else, right? And then once you clamp it right above the sublingual ducts, then you take your other beaks and you basically just ride it along those already clamped straight mosquitoes. And then you make a little V. And then you elevate it, and then clamp it. And then now you have the lingual tissue of the frenum ready to be excised. And then you can see, man, it's like such a simple thing, but like people do these and it's so bloody. But if you can do it this way, this is one way, and it's almost bloodless for the most part, right? So you just take the 15 blade and you're just riding it right along the straight mosquitoes, and you have the crushed capillary beds of the frenum, and so you don't have to worry about much bleeding. And you can see there's not much blood. You take a pickups, you excise the tissue, and you still have the mosquitoes clamped, and then you can kind of see that, I call this the mohawk, because basically when you remove the straight mosquitoes, you have the crushed capillary bed and the little tissue, and it looks like a T, like an upside down T, or a T from the upside, or the top side, and it looks like the arrows got moved a little bit. But so the top portion of the dorsum of the tongue looks like this. So if you can imagine the rest of the tongue taken up where the words are, and then you're just going to basically pass the suture through that little mohawk area. It's so simple. I don't know how you do it, but man. And then you can see the straight mosquitoes are still attached, but and then you do one interrupted, and then you run it along the dorsum of the tongue all the way to the depth of the vestibule where the tongue, where the two beaks met. And then that's a little blurry, but you can kind of see the, I think he got pretty far in that stitch. I think there's a better picture. So that's basically what you're doing, and I can walk you through this in the course, but it's so simple. I had to think of a way to translate that to a slide. Again, the picture's a little blurry, but you can see right here, that's what we're suturing. And it's like I said, bloodless. Because as long as you keep that intact, because you could basically take the tongue and you could pull it right to left from the midline, and then it would just gush with blood. But because you had the straight mosquitoes crushing all that, you excise, it just stays together. And so you see the pattern of what the straight mosquitoes look like. And so again, picture's blurry. So this is placing the, you can see sublingual ducts, placing the straight mosquito.
I mean, is it like if you hear the word diode, are you guys like, oh no, you don't use a diode laser ever, right? Versus like, I mean, because one is cauterizing, you can remove the tissue tags that are left over, right? So there's not like the little tissue hanging out afterwards and everything. Are you guys major unfans of diode lasers that many of us probably have in our practice?
Look.
I struggle.
No. I've used the diode. It's not that great. Like you gotta score it and like heat it, and you're basically heating it up really hot. Why not just use a Bovie? Why not just use electrocautery, right? Like that's pretty much what it is. So that's in my opinion. And I do that. I mean, I use the electrocautery. I have a battery operated Bovie, but you can get one that plugs in and does all that. So I don't know, I just found it really tough to use, and it was on my kid. Because I didn't have a laser at that time, and I had scissors, but it was just like, no.
Wait, there's a provider a pediatric dentist, and he's got it, and he uses it. You know, like I think like it's kind of, you guys have it, like right, what's cost effective. So like if you feel comfortable using it, and that's what you've got in office, like you can use it.
Yeah.
He's not a fan. Like we have a CO2 laser now.
Yeah, for sure.
Yeah,
No.
which is like, but like, you know, what's available. Like if you have a diode, go with that. If you don't have any access to any, like this is a great, you know,
That's why I wanna-
no zero, like pretty minimally cost.
I want to give
Way to go.
the scope of what you can do, because more people, I think, need this. And we're missing it on the diagnostic end. The assessment end is like super muddy. And then the treatment of it is like not that hard. You can use a diode. Like it works. It's just what I experienced with it when we did use it is just the post-op. Like they had some more swelling and stuff, but like, hey, whatever works, right? That's what I want to give. I probably wouldn't, I don't have a diode, but yeah, so I'm not like 100% opposed to it at all. So I don't know if that helps give you a scope. And then this way, like, is this going to work on an infant? Hell no. You're not going to be able to do this, right? So you kind of have to have either something that, like a scissor, which is still a tried and true technique. Some people have difficulty extending the scissor to get the posterior tie, right? But I've been successful with it. It's a lot more bloody, you can't see, and it's like a little bit more spooky than some of the things I've done in the hospital, because the infants, you know, all that blood's going everywhere. So that's where the laser, God, it's just awesome for the infants, right?
Yeah, new moms don't like that.
They don't like blood.
They don't
yeah,
like that
yeah,
very
I mean,
much.
you know. No, we don't suture on the infant. And we also don't do like general anesthesia or any sedation or anything, right? I mean, that's the beauty in it. We use topical, and we could use some, I guess, Lido, but like, you know, we let the topical sit on for 5 minutes, and it works really well. And I've used the laser on myself, no local, topical, and, you know, topical and local. And it's not bad, at least the CO2 laser. So, I don't know. So if that helps, give you any context. So, so that's kind of the end product of a good, you know, release and a suture. And so this patient, gosh, I think I have a picture pre-op because it was so tied.
Is this just, this is without laser, right?
Yeah.
no laser,
No laser.
right? Like I want to share this skill set because I think if you don't have a laser, which costs a lot, right? Like you could be able to do this, and it's so easy that I want to get people reps and doing a bunch of them, right? And laser, same. I think that was an earlier slide. So another one. Well, that might have been the same one. Again, these slides are kind of all over. Do they need a second release? I don't know. Functionally, like now that a lot has taken place in the last 10 years as far as research and people being aware of it, a second release on some of these patients wouldn't, in my wheelhouse of what I used to do in hospital dentistry, heck no. I mean, like you're not getting a functional assessment on them. They'll headbutt you, they'll spit, they'll kick you in the face, like, because they're they have the mind of like a 2-year-old, some of them, and so their intellectual disability and delay. So, but out in the real world practice outside of the hospital, yeah, I mean, they might need a second release, but at least you can check it, right? And honestly, we hadn't done any secondary releases, right, or staged approach, but a lot of that is newer in my scope. The follow-up on a lot of these hospital patients wasn't great because they're traveling 10 hours to come see us from the 5 surrounding states when I was in Arkansas, and then Oregon, Alaska, Montana, Idaho, all 5, 6 surrounding states. So the follow-up wasn't that great. But with our clinic now, it's so much better, and so we're getting really good results. So laser, CO2 workflow, we have a small clinic in Hood River, and access to other clinics, but you don't need much, That's the laser I have. I love it. I researched it when we started picking up on these because I didn't believe that you could make a business out of just frenectomies, but God, the need is so high, and so I want to share that again because I want everyone to be able to do it in their practice. So here's a bunch of pictures we thought of like babies or infants, and then I think we have some other ones. I don't know where we're at in the slideshow. So this one we thought was pure. I didn't, but the chiropractor / lactation specialist thought this might be Pierre Robin.
No, that was a specialist before
Yeah,
her.
that Seattle Children's Hospital. Yes.
Yeah.
And so they didn't know, and so I'm like, all right, we've done a lot of these. Let's check. I've seen infants with that syndrome. We'll see. I didn't think so. We ended up doing it because if I did it, like I had the airway kit, I had everything lined up just because I didn't know, but I'm like definitively because I couldn't get in contact with their ICU team or whatever service they were with. But you can kind of see you got blisters. We'll go through all this in the course, but you can see lip blisters. They're kind of faint, but right in there. Frenum goes all the way down to the alveolus. Is that distinguishing, like if that's the case? No, it has to have symptoms, right? So we talked about the symptoms, so you can kind of see they're snotty. Is that the end-all be-all symptom? No, it's one sign that most of our kids that we treat have some type of snot, and they have lip blisters. They're trying to suckle. They're trying to,
They have friction.
friction,
While they're
and
trying
so
to nurse, because they're not getting a good seal on their latch. It's not a huge concern for most lactation consultants, and so it's not usually what's contributing to symptoms, but that's why they're getting those blisters on their lips.
So, these are the little goggles. We like the parents to take the pictures because they kind of look like minions, so sometimes do that. But you can see a big in the right on the lip. You can see big lip blister there. You can see there's blanching upon elevation. There's I have a bunch of pictures. That one's not as clear. And then tongue. So I don't remember what classification this was as far as Kotlow goes, but I think if I remember correctly, it was, I don't know if we have a good picture of it. Well, no, we don't, but we have a bunch of cases, so I'm just gonna keep going. So that was post-operatively, right? We rehydrate it. So the laser vaporizes the tissue, and that's not just a nuance, it's heating the water molecules up and vaporizing, and it's one of the most gentle things in terms of surgery, and I've done a lot of surgery. Scalpel blade, diode, it's one of the gentler things that I've done, and then especially on infants, and we don't get any post-op calls. It's so crazy, but that CO2 laser works so well. And pretty minimal to, if any, bleeding. So you can see tongue. You really want to get in there and create that diamond shape. And on infants, that alone will be magic to the mom and the infant, Diode, and they'll be able to feed after this. I'm still amazed at every case we do that it works, and it really does. So this is a 1-month-old. You can see lip blister. We do submental pictures, lateral, and then you can see blanching at the alveolus there, and it wraps around. So that's a Kotlow class 4 on the lip. And then that's probably a posterior tie. We assess all these before we do the surgery. I didn't sit there and document every one for this presentation, but and you can see post-operatively. It doesn't take much on the infants with the laser or the scissors. Scissors is just a lot more bloody. 21-day-old, this was just last week. Dr. Kahari's big in the space. He's right down the road. We're starting to get referrals that can't get into him, and we've really proven our ability to successfully have good outcomes, and that's generating a lot of new referrals. So you can see snot. Sometimes they have a blister extending from commissure to commissure. It's kind of crazy. And I'm just going to keep blitzing through these. And I think they'll be able to get you a slide. So this is just a comparison. There's nothing there, right? Like there's no frenum. Why does this thing develop? Well, right around, it's between like 8 and 12 months within the womb. It should dissolve. It should, by apoptosis, go away. And it doesn't. Failure of that, whether it's completely or incompletely. So this is done with scissors, not by me. But you can see the severe scarring right here. The lip looked great, but the scissors caused that scarring. I'm not saying it does that all the time. It's just this case, unique circumstances. Whoever did the release, I don't know if they.
Oh, this was the mom was sick and she wasn't able to do stretching afterwards. The whole family ended up with a stomach bug, and she did not want to deal with that. And the baby was already sick, so they missed probably a few days of stretching, and therefore they had reattachment.
And so you can see pretty significant scar tissue. So this was a tough case. This was just like, what, last week, 2 weeks ago? Mm-hmm. So you can see post-operatively. I don't know if I showed the lip, but I think I have a good one. And we did do a video of this one, right?
Yeah, we have to.
I don't know if the video worked that well.
Yeah, I mean, it's already 5.
But that was a lot of scar tissue. It took me maybe an extra minute to sit there with the CO2 laser and make sure that we were deep enough. And this baby's doing wonderful. And we get feedback on every one of them. And gosh, we've only had 3 revisions so far. Out of the, I can't even count how many we've done so far. But we rehydrate the tissue with just sterile water on woven gauze, and yeah. So this is a 2-year-old. So we do these 2, right? Mom's a local nurse. 2-year-old, she couldn't brush her teeth, speech issues, and mom was like, she needs it done. So she helped us stabilize patient. Little Lenny's so cute, and she's doing great because it's been a year. And mom came in with newborn right out of the hospital. So the laser, this one's laser, yeah. So we rehydrate that tissue, and that it almost looks like it's charred, but no, it's not. It's vaporized tissue, and that's just how it looks. It's bloodless, right? And so, yeah, she did awesome, and it was so quick.
She looks super narrow. Does she have a lip or a tongue as well?
No, I know. So and then let's see.
Her brother did.
Yeah, her brother came in with one. Mm-hmm. And so she's doing great. Her speech, because we just saw them 2 weeks ago, her speech, she had like people that didn't know she had the lip tie, the frenectomy, and she had her mom had like 5 or 6 different people tell her, oh my gosh, like her speech, she doesn't have any speech issues anymore. And she was in speech therapy, which brings me to another point. There was a 7-year-old with Cruzon syndrome at Arkansas that I saw. I have a lot of stories, sorry. So 7-year-old, we're in the OR. We caught the I think it was tongue and lip tie, but definitely tongue. We called mom because I wasn't expecting that necessarily. Out of the OR, got the approval and the consent to proceed with the lingual frenectomy. And then, you know, we didn't know she was in speech. She had all these issues, breathing, all this stuff. And then, you know, Cruzon syndrome, which is a craniofacial anomaly, and it affects a lot of different things. So 2 weeks later, we see her postoperatively. And brother, who is 4, I think, she started crying because she's like, oh my God, she doesn't have any of those things. Like, it was just crazy because I didn't expect that. I was like, oh, hey, how you? And she's like, I'm so grateful. Like, you guys saw it, addressed it, managed it, and now she doesn't have speech therapy. It's freaking nuts. So then brother also had Cruzon syndrome because it's a genetic component. There, I forget what percentage it is that gets translated genetically, but we did brother who was 4, and same thing. Removed him from speech therapy, all that stuff. And it was just part of a dental rehab where, you know, we probably did some other stuff too. So, yeah. Here's the 13-year-old you saw earlier. So this didn't, like, do we really need to do a lip tie? Well, orthodontist primed us ahead of time that she had, you know, diastema before he repositioned them. So we did it, and she's had, he was super impressed because he knew all the pre-op before the teeth were repositioned. So, and you can kind of tell it's V-shaped, it's pretty thick, high up there. I can move her lip pretty well, but so this wasn't one that we did with myofunctional therapy, right? I mean, so, sorry, you had your hand up before.
When do you like to do them on people that are ortho before, after, or during regarding scar tissue?
Say that again?
When do you like to do them on people in ortho before, after, or during pieces of scar tissue?
Great question. Whenever so if you don't get those fibers deep, it doesn't matter when you do it. It's probably going to have some issue with it. So it depends. Like we caught this one post, you know, the reposition of the teeth. I don't really have a preference, honestly. We just do them per what the orthodontist thinks. Yeah.
It seems like the orthodontists are the ones who are more, like, if there's a little controversy. Yeah.
No.
Yeah, and we haven't seen it one way or another.
Yeah, so I'm indifferent. As long as we have a good outcome, and I haven't had to do a revision on anything like this. So it's like, all right, well. You can see how thick it was from the lateral aspect. So that was a good amount of tissue, but it's pretty high up there, right? Like a lot of them, they're at the gingival margin where they're low. But, you know, we did it, and she's in good shape. And so the orthodontist referred us more patients, so that's my sign, like, we're doing something right. No, so yeah, she had a good success. She sat through the procedure beautifully, no sedation or anything, if I remember correctly.
Yeah, not her, no.
So she had a great smile, did great. So that's something you can do in your office easily, right? Here's a 40-year-old, self-referral, migraine, had a ton of other symptoms we couldn't remember.
I had
We have, well, I didn't want to type that much. So a lot of symptoms. And grinding, clutching, airway issues, right? And so one of the things that my buddy started at Arkansas Children's Hospital was an airway clinic. And that was like, what, 2016, I think? I'm not sure how active it is now, but that's one of the areas I started to get into and then left. So I don't have that much experience with, you know, all of that other than with the NAM and stuff. That's an area I'd love to branch in because this affects all that, right? And you can speak to that more. So she just wanted a tongue release. So I'll just go through this case. You can see mentalis is maybe a little tight and over stimulated. Her labiofrenum didn't look that significant, but her lip, if I remember correctly, was super tight. And then tongue, you can see the scalloping of the tongue. That's one sign, right? That's not the only thing, but matched up with our symptom list that you saw earlier. And then you can see bruxism. She's only 40. She's worn away quite a lot of teeth or tooth structure. And then elevating, so that's kind of checking the how passively, because she's not moving her tongue up, how passively how much I can manipulate the tongue and see how much the floor of the mouth moves. And it was pretty significant, right? And then checking how close it is to the tip, although that's like one of the least specific symptoms, right? Like if it goes to the tip and there's no symptoms, I mean, do you really treat it? Do you need to or not? Can they stick it out? Is not a good test. I mean, it was on a couple I caught this week that like this, and like they couldn't stick it out, right? But for most cases, that's not going to help you catch a posterior tie. So the assessment with your myofunctional therapist works really well, but if you're on your own, I mean, you're checking with Zaghi's different scales, and we can go through those. And then here's a suction test. So that's part of that, where we're seeing if she can get the posterior aspect of her tongue to the palate, and she failed that miserably. And then wide open, and then see if she can remain open and how functional the tongue is by the anterior aspect of the tongue or the tip of the tongue elevating to the backside where the incisive papilla is. You know, that alone doesn't, if it's only halfway, I mean, that's like 50% reduced of what most or a lot of people can do. So we did the frenectomy here. You can see nice diamond, and then this is what it looks like on an adult with the laser, right? We got deep, and it's gonna be sore. So this is a lot different procedure with the laser than the infants with the laser. This is a lot different than the scalpel to straight mosquitoes, right? We can suture this. I'm still kind of toying with that because I used to suture everything, but then I had it sutured on me because I was tongue-tied in dental school, and I feel like I got some release, but it wasn't adequate. No post-op instructions, none of that stuff. It was an old oral surgeon who used silk. Fun, because my tongue was like zinging for a week.
We've done sutures too. It's
yeah.
like...
It just depends, right? I mean, you can take one and close this up. It just depends on the case. So we're navigating those waters, but I mean, we got deep, right? No bleeding though, right? So that's the laser, right? I don't remember if this is post-op. Yeah, this is post-op. Her tongue is numb, but we just wanted to see how much more function. And then the big thing is all those strap muscles just relax. And it's amazing to like kind of see it in her face. And then in the infants, you can feel everything just relax. It's like releasing a full thickness flap like on a wisdom tooth, where you release it and it's just the flap opens up. So it's kind of a similar thing. I
think these are the videos.
Oh yeah, I don't know if those are going to show because I was going to show you videos to play, but it doesn't.
Any sort of vessel vasculature?
Absolutely.
Right
Yeah.
there, 'cause I'm getting in there, I'm like, is the yellow adipose?
Yes, it is. So yep, you gotta know your anatomy, right? You have a lot of vital structures in there, and so yeah, that's one of those things where you can cause some pretty severe damage, collateral damage.
And there's not a lot of structure that's besides vasculature, like in the fibrous bands. But once you start hitting the base of the tongue, then it gets a little
Yes.
Wild West.
Yep, it is. Yeah. Yep. So yeah.
You use cotton tip applicator to...
Yes. So that works beautiful. And so I know Zaghi uses that. I love that because you're gently kind of, I don't want to call it blunt dissect, but it's that concept of just rolling that and separating. And then do we need to do more or not? And so you're assessing the patient. They're totally awake. So, you know, the adult's a different animal. So I don't know.
I don't think they're going to play.
Post-op stretch.
I mean, so post-op stretching, there's a lot of research. There's no definitive way, yes or no. We work closely with Myofunctional and lactation. However, if your patient's not doing that and you're providing them those stretching opportunities, we kind of have simplified it, and it kind of changes infants, children, and adults. The goal is to like prolong the healing process so that you're preventing reattachment, right? And you're helping them get used to that new mobility in their tongue as well. So we kind of, there's a multitude of ways to stretch. There's a multitude of ways that it's being kind of educated, and they're not really seeing what's working, what's not fully, other than stretching is helping. So we're having a lot of success with some different techniques that we use, and we're continuing to modify that constantly in what we're seeing and what type of feedback. But the infants, we have a few different techniques, and then it's getting a good stretch in there so that you're just not having them come back in, having scarring, or having to do a revision. And honestly, like working with Myo and Lactation, they're your follow-up people. They're monitoring, are they stretching? Are they not stretching? Hey, it looks like it's reattaching. We had, one of those out of many where the baby just,
Low tone.
They scarred a lot, so.
Low tone, possibly some scar tissue, congenital condition that, you just can't predict. So that's why we work closely with lactation specialists, so.
Mm-hmm.
What's next? So we were gonna do a live demo, but I guess we don't have time for that, so that's okay. We still have the instruments, so if anyone's tongue-tied and wants to volunteer, we can whip that out. But anyways, full course, hopefully Hood River. This is the case that we caught. I was hoping to, demonstrate on this.
We still might get to.
Yeah, we did some wisdom teeth in the wisdom tooth course, and I'm like, dude, you're tongue-tied. And he's like, I know. And so I didn't have my straight mosquitoes because I didn't bring them. But anyways, so you can kind of see, this is a slam dunk. Like, yeah, you're tongue-tied, right? So you don't even have to go through all the assessments. We still do, but he's severely restricted. That's as much as, so wide open, right? As far as they can open, and then how much can you bring your tongue up without closing? That's it. And so functionally, that is like less than 25%.
And he's had a series of symptoms in conjunction with that tie.
Yep, that he's well aware of, and I forget the whole backstory because my brain gets full sometimes.
He has had a series of events leading him to this place.
So that's us. We love being here. We love CSI. It's our surgical playground. We love sharing, growing, giving, and so, we're here. So are our kids at one point. And so that kid is what got us into the frenectomies as kind of a thing, because I fought it for so long, because I'm just like, I do other surgeries, that's so simple. Like, why, how can you make a business out of it? But he was tongue and lip tied, and Bethany and Paolo went through the journey of undiagnosed, and then, just the whole gamut. And we thankfully, because this is our third kid, who was tongue and lip tied, got the proper diagnosis and treatment, and then actually breastfed.
Yeah.
Where the other two, we didn't,
weren't,
right? So that's
that was the whole thing.
Direct impact, and that's why we're here giving this or one of the reasons why we're here. That's EJ, and we have a 15-year-old. We were at Tongue Point picnic area. This was in Olympic National Park or Forest, or no?
No,
park?
It was like Baez. It's in Washington.
And we're like, Tongue Point, everybody stick their tongue out. You can see mine scalloped still because I tongue thrust. I need someone that I trust to revise it. And then that's us in the OR. So we do OR case, or we did OR cases. We started hospital down service, but that's a lot of what we did. And then, what do you know? There's the slide again. So.
Yeah, so we're just trying to see, is this of interest to people, developing it beyond just, doing a procedure, but allowing folks to get practice, doing it here, doing it at Hood River. So, talk to Chris Richards, give feedback. I think they're going to ask about it, but we're just seeing, we could talk and really go in depth on a lot of things. So this is more to generate interest and see if this is something that would be helpful in practice. We think it would. I just talked to a patient. Their hygienist caught tongue tie, and then the dentist they've been seeing was like, oh yeah, that's a tongue tie. So, and he's not doing it. Yeah. So I think it's just kind of being dismissed and so forth in some respects.